I'm happy to talk about something I really enjoy talking about, and that is Gait. And I really wanted to focus today's talk, particularly on the Gait retraining aspect, because probably most of you are well versed in the fact that walking and cognitive decline and dementia are all related, and that walking changes. And actually, when I started looking up a few things before giving this talk, most of the research is all around relationships between slowing of walking and changes in walking, and how that is associated with various forms of dementia. But that's not really what I'm interested in so much. It's more interested in what do we do about it, and what the hell is a neurological physiotherapist, and how do we help out? So that's what I want to sort of convey today. See, I think it's I don't know about the rest of the world, but in Australia there's these definitions that that we talk about in terms of reablement, restorative, and then we still use the word rehabilitation with regard to dementia. And the paper came out earlier this year called Understanding the Australian Aged Care Sector, Reablement Interventions. And the bottom line is, when you read this paper, is everybody's confused, and we don't really know what these terms really mean, and the close definitions of them. Is reablement just a soft form of rehabilitation? But having now taught in the rehabilitation field for nearly 20 years, it's obvious that dementia is right in the rehab. And so when we're talking about walking, we're talking about rehabilitation, and there's probably really no two ways about it. That's probably the word that we should continue to use. And the good thing is, probably for the last 4 or 5 years, we're starting to see a re-emergence of sticking with the term rehabilitation, because that's a far more accurate description of what we're trying to do. And the goals of rehab are pretty clear. We're trying to learn new skills. We're trying to either learn more skills. We're trying to maintain people at their levels, especially trying to maintain activities that are important to them. We're also trying to prevent things like prevent injury, prevent falls. So they're the roles of a neurological physiotherapist, and so that applies very much to dementia, and becomes really important in relation to walking, because we want to learn how to walk better often. We want to keep walking, and we want to prevent falls and injury, and maintain our confidence levels. So it's obvious that Gait and dementia are well linked. As we get older, we know that over the age of 60, there's a percentage of people, maybe 10 to 20% of people, walking starts to change. That's just and then as we get into 80s and 90 years of age, majority of people have changes in their walking. And walking speed is also associated with your overall health. So if you go to a medical clinic and they get you to just walk 6 meters, and your walking is slower than the norms, then there's a lot of follow-up to do to try and work out your general health levels, your cardiovascular health, your neurological health, and all these kinds of things. It is associated with cognitive decline. Many dementia types have been associated with changes in gait, but there's a bigger picture. The next thing we're going to try and figure out is what we can do about it in terms of changing gait and continuing to walk, which is so important. We also know a lot, and there's a large review here from Studensky that looked at sobering facts about how slow you walk and your mortality rates. And so it's important that as early as possible we get people walking, and we keep their skills in walking as much as we can. So what about the reverse? What if we actually got somebody with dementia and we are working on their walking? What health benefits do we have? And there's some things starting to emerge where it might stabilize cognitive function. A paper came out this year in the Journal of Physiotherapy, looked at long-term community-based exercise programs, improve function, so improve activities of daily living, and that becomes really important. And it's really exercise programs that are set for the long term. This is not just a 6 or an 8 or 3 month program. It's really setting people up to improve their walking and maintain it in the long term. In the neurological physiotherapy world, there's a lot of talk about this, where for some people, are we just trying to build a bigger engine? As in, we're trying to get their ability to walk for longer. We're doing to basically run with more horsepower. Or in some other people, are we trying to build a better engine where we're trying to look at their ability and their quality of their walking and their skills involved for the walking? What will dictate that is obviously people's presentation when we assess them, and also what their goals are. Do people want to walk long distances or just walk safely around their home environment? You can imagine how everybody's home environment is completely different. And so these become really important to set those goals and become clear about what we're trying to work on, because then we've got different kinds of measures and different milestones we might be walking towards with their rehabilitation. We've known, even though the evidence is relatively low, we've known for quite a while now that exercise sort of stands out as one of our best interventions for dementia, as for overall health. And we know that if we involve exercises that actually involve a bit of thinking and problem solving, there's probably an element, an extra element, as well as the cardiovascular aspects for neuroplasticity. And pretty much if you look at interventions that involve some problem solving and learning, that neuroplasticity learning effect is also a protective effect. So that's going to mean that many brain functions are going to benefit from a slightly more intensive cognitive program. And some people think, well, what's walking got to do with being cognitive? We think cognitive, we think of things like, reading books and doing crossword puzzles and doing mathematical solving, but walking is very much a cognitive task. And we've learned over the last decade, we've realized that that's really important in neurological physiotherapy. We also know that when everyone says that exercise is important, like when they say diet's important, that's absolutely fine. But exercise needs prescription. It needs support, and that's our job. It needs follow-up to ensure that we modify people's programs as they improve or as they decline, or if their confidence levels changes, or if their situation changes from any other reason. And we also do it in the context of rehabilitation. That is usually just means we're one-to-one, we're setting goals, and we've got some kind of purpose with that exercise rather than just a generic exercise program. So it's more than just a suggestion. And the things we focus on is strength and balance. There's a fitness component to walking, and then there's the actual walking itself. So for some people, we just do a lot of walking and a bit of fine tuning. For some people, we really need to up their fitness levels to walk to the amount of walking that they need. And some people's balance, strength, and also I would say confidence may need some training as well. So not everybody's the same. Some people will need a bit of fitness work before they do more of their walking. Some people need a bit of balance work before they do more walking. And some people go straight into the walking and then fine tune their balance. So everyone's going to be a little bit different, and it will change with time. Another paper that came out just last year, which is really nice because it's talking about how we assess mobility in advanced dementia. And you can see all of these themes on this slide, from bed mobility, sitting, standing, postural transitions. That's like going from lie to sit and sit to stand, and even going from the floor to standing, assisted transfers, walking, wheeling. And then there's all these things we have to take into consideration, from vision, reaction time, history of falls. What if you have arthritis? What if you've got diabetes? There's many, many things that we have to consider. And I'll put a ring around the things that we're focusing on today, which is more the standing, walking aspects. And these are the things that I spend a lot of time with as a neurophysio, and we all do, in terms of keeping people walking safely. And the other thing is, I have to say this, that this is a paper by some very good researchers, particularly done a lot of work with Parkinson's disease. And we know Parkinson's disease also affects gait in sometimes some very bizarre ways that we have to try and rehabilitate. There's factors to consider: motor symptoms, non-motor symptoms, so things like autonomic system, fluctuations with your medications, fluctuations in blood pressure, these kinds of things, comorbidity issues, biggest ones that I deal with a lot of things like tendonitis and osteoarthritis and other elements of pain, environmental factors, and then also, personal preferences and all these kinds of things. Now, what this paper is talking about is how to gather research to help us with our more personalised, patient-centred care. And pretty much it says that it's going to take decades for us to get the research evidence to be able to tell a physiotherapist with some kind of concrete evidence base as to which patients present with what problem as to what we should do. But as a practicing physiotherapist, we don't really have time. We don't have 20 years. So I would say what we really want to do is start thinking about these issues now, and have a logical and sensible approach to give people the benefits of what we already know. So randomized control trials are the best form of evidence, and they should continue. But right now, there's probably ways we can accelerate the implementation of what we already know, rather than waiting for randomized controlled trials. There you go. That's my research rant over. But let's get back to some other things. Why is Gait so important? Now, if you read literature, if you talk to people, falls often comes into it first. And that you can understand why that's important, because falls can be devastating. It means people can go into hospital and never come back out. And so it also results in a loss of confidence, a real fear of falls, and affects mobility. But you can see why funding would head towards falls as well. But, sometimes we have to also consider other things like independence, and people maintain their walking for the things that are important to them. Confidence levels becomes really important. So as a neurological physio, I would be saying to people, compared to 12 months ago, what are the things that you're not doing now that you were doing then that you'd like to do, to get a bit of a picture about what might have changed with their confidence levels. And also, there's a very simple outcome measures to use to try and determine how confident people are at doing certain tasks, because that becomes really, really important. So self-efficacy is now probably one of our with quality of life, one of our most important outcome measures. And the other thing to consider is physical activity levels. If we're walking, then we're getting the physical activity health benefits as well. So there are many different themes as to why we want to keep safe mobility going. There's also some other challenges that we've got in terms of the idea of rehabilitation. We've certainly, as I said at the very start, we've softened our approach a little bit with dementia, probably because of stigma associated with dementia, and probably we over-medicalised things. When you over-medicalise things, rehabilitation doesn't always come to the top of the tree. But I think when you could see somewhere in a second highlight area, it says a person with dementia should be encouraged to exercise, eat well, keep doing as much as themselves as possible. It's a bit flippant. I think we need to, if you're going to be exercise, get some supervision, get some support, because without that, you're not likely to improve your walking and to improve your exercise or change your lifestyle in the longer term, which is really important. What are the key outcomes? Well, the first and foremost, we've got to ask people with dementia themselves as to what is important to them. And then we know what we may be measuring as a physio. In some clinics, there's no doubt about it, we spend a lot of time doing outcome measures and not a lot of time doing treatments. So if you are going to do an outcome measure, think about things like goal setting, or is it more than that? Quality of life, self-efficacy, which I said before is about confidence. Are people happy? Are they happier than before because of their level of mobility? Ability to adjust to a diagnosis and then being able to still be proactive in some way. And also planning for change. So as people's mobility changes over time, we can still adjust the exercises so that it just doesn't stop. And many people, if we're not supporting them at close enough intervals, sometimes exercise programs and walking programs just do well for a while, and then they just halt very suddenly. And I like this quote, even though it's from stroke rehabilitation paper. I like this quote. It's that I'm not fighting for my life. I'm just fighting for my lifestyle. In other words, what makes me me. And I think we try and keep that first and foremost in our rehabilitation for walking. And if you think about walking, a lot of the research would talk about walking and walking speed in straight lines. If you go to a clinic, they'll often get you to walk and you walk 10 meters down a corridor. But we all know that walking is a bit more than that. It's standing, agility and turns. Imagine what your walking is like when you're in the kitchen and you're just moving between the kitchen bench and the fridge and back to the stove. And then you're wandering over to a dining room table. All the little backward step, the twists and turns, the occasional stumble and quick step that you have to do, that kind of agility training is probably far more important to some people than the straight line stuff. And that becomes really important part of gait retraining. Even when you're walking straight lines, there's gait ignition, which is taking the first step. And a lot of people with cognitive decline and dementia have gait ignition problems, a bit of hesitation with the first step. Your feet are not going as quickly as your mind would like them to. The ability to accelerate and get to a cruising speed. What about the ability to slow down and also the ability to stop and do that on command, that voluntary control? All of those things will need practice. And depending on what difficulties you have, some of those things will need more practice than others. With walking also becomes physical capacity. What that means is, are your muscles strong enough to do the walking that you need? And do they have the endurance to do that? And do you have the cardiovascular fitness to walk those longer distances? So as a physio, we've got a test called the 6-minute walk test. And that's walking for 6 minutes and then seeing how far you can walk. Now, that has a lot of elements to it, not just your walking efficiency and speed, but also a bit of fitness there as well. And the efficiency over long periods of time. So building people's physical capacity with walking is really important. I've also put load management there because we can't forget that we are getting people to walk and do new movements, but they may have a bit of osteoarthritis in their knees. They may have a painful hip. They may have a bit of tendonitis around their hip. They might be dealing with some low back pain that, after 3 minutes of walking, my back starts to hurt and I need to sit down. And with those kinds of musculoskeletal issues, they all need individual management. So you can't just start a program and start walking, 10, 12, 15 minutes, and you haven't done that for maybe a number of years. The body is going to give some kind of, it's going to complain sometimes. And sometimes you've got these underlying injuries. Now, it doesn't mean we have to stop or be overly cautious. It's just that we have to manage those loads. And even with things like osteoarthritis and tendonitis, which or what we call tendinopathies now, is that load is important to keep doing. It's just getting the right levels. And so as physios, that's where we're working with our colleagues in the gyms, personal trainers. We're working with exercise physiologists, just to make people aware of the full medical history and some of the issues we may have to sort of adapt to ensure that we don't end up with slight injuries or increase in pains, because that changes confidence, that reduces the dose of practice and all those sorts of things. So there's a lot to consider there. Inevitably, people can have injuries anyway, and then we have to manage them. But we may want to manage them and keep walking. And then increasing and maintaining things over long term. And that's really building up people's control, looking at the support networks around them, inviting and encouraging other people to be involved. So one of my roles is to talk to physios out in the community, talk to exercise physiologists, and more now working with gyms to help people feel like they've got a little network of support around them to keep their walking going. And the way I like to talk about it is, think like an elite athlete. I know it sounds funny, but think like an elite athlete, but your event is walking. So all the exercises and all the things that you're doing are in relation to walking. Because when it comes to exercise, everyone's going to sell you an exercise that they're going to tell you is important. But how is it important in relation to what's important to you? And if walking is your event for your Olympic event. Declining mobility is also an issue, because for many people who are walking, and they may be walking all right, if you're not doing a lot, for example, if you're just walking around the house, you're not getting out of the house. So you're just walking from lounge room to kitchen to bathroom to bed, and there's not a lot going on, and you're safely mobilising around the house, that kind of mobility level, it means you're going to decline over time relatively quickly, and it can become a slippery slope. So it's important that we keep people walking with neurological conditions at a certain level to maintain just their level of mobility. And that's a worthwhile goal. So it does mean upping the ante. What's happened with this COVID pandemic is that we've done a little bit more work with people who are stranded in their house and setting them up with walking programs, circuit trainings around their house to just keep that level of mobility up beyond just pottering around the house, so that we can get an adequate level of exercise dose. This slide I'll use a lot with the physios, but here's some things we think about in terms of walking. Like we talk about retrieving balance and stepping strategies. We talk about location speed. We talk about landing, multiple steps and walking sequences, which I'll talk about in a minute. Turning, different types of turning. How do you turn to move from one room to another versus turning to do a 480-degree turn? What environment are you in? So sometimes we do skills with people, they're fine in the physio gym, but now can they do that when they're outside in the car park? Or can they do that in the context of their own lounge room? The physical environment and the spatial environment affects mobility quite profoundly. So we need to practice those things. We're often talking, when we're talking dementia and walking, but we're talking high-level gait disorders. So balance is always a factor. Stepping is always something we tend to practice. Planning deficits is what we practice more and more now. So that is using cognitive elements to pre-plan our steps for things like obstacles, unexpected perturbations. Things like we look at gait ignition problems, so we need specific practice to do the first 2 steps where people a lot have hesitation and freezing issues. Set shifting is a problem that's used a lot in the literature, which basically means when you walk and then you deviate and then you walk again, let's say you walk through a doorway, that involves you sort of slowing down, negotiating, double checking a few things and then going into another walk. So it's a bit like changing gears in a car. That ability to smoothly change gears is set shifting, and that is a cognitive task that needs a bit of practice. So if you've got a set shifting problem or you've got a gait ignition problem, we don't want to have you in a physio gym just walking and you're walking well. If you've got a set shifting or gait ignition problem, we need to practice those. We need to practice them over and over again. So we have to stop, start, or we have to move and change speed and these kind of things, because that's what your brain needs to compensate and adapt to and to do things differently. And dual tasking, this is the common situation that if you get people to walk and dual task, so walk and talk or walk and carry a cup of coffee, like we've been doing this morning, that's a dual task. And immediately what we find is people slow down. That may be a good thing because it's a just-in-case strategy. It's being careful. But we know that when you start adding more tasks in, more cognitive tasks in, performance can decay. Now, as a neurological physiotherapist, we like to use dual tasking, particularly as a skill is getting better, to force the brain to do things more automatically. But then in other situations, we want to avoid dual tasking because the performance might decay so much that it really throws your confidence, or it results in you falling over. And it's just weighing up the risks, thinking about the goals, and trying to determine how we're going with the training and how confident do you feel to try some new things. Obviously, dual tasking is something we do functionally a lot. So whenever possible, we try and train that, particularly as a walking skill is getting better with practice. And that's certainly something that we think about, not just building into outcome measures, but also our treatments. And here's a bit of a slide just to show that when we do gait retraining with physios, these are the things that we cover. So if you look at the top here, we look at things like attentional focus. When you're doing walking training, what are we asking you to focus on? Are we asking you to focus on your foot or your knee? Or are we asking you to focus on a target further away and that you're trying to get there by a certain time point? or we're asking you to visually scan to look for something. Whatever you're cognitively attending to becomes an important part of the training. The ultimate is we're trying to get people often more externally focused on things, because when you walk, you don't really want to be thinking at the top of mind, conscious thinking about your walking. We may want you focusing on other things. But in some other situations, we do want people to concentrate on their walking and think about their stepping, because that's the way they perform better. Gaze and saccadic eye scanning, like your visual search strategies, becomes important for gait. So walking and looking, walking and checking things around you. And how often do we hear where people have stumbled or fell and all they did was turn their head? And so much of our training is about balancing with the head in different positions. So you might be looking up, you might be looking to the left, you might be looking down, scanning for things on the floor. You need to be able to balance, you need to be able to step with your head in those different positions. So it becomes a training strategy. We look at the whole body and how do you balance? Generally, what we focus on is what people are good at, and then figure out what can we add in to make it better, rather than just focus on people's impairments. Sometimes we're looking at what you've got in terms of strength. Now, whenever you've got some strength, we know that we can always get you stronger. So there's nothing wrong with getting strong, but the tricky thing is trying to do that in the context of walking. Range of motion and things like your ankles and your hips, for example, and your trunk will affect the way you move. Other things that we may be dealing with, like things like spasticity or sensory changes, stiffening strategies when things get nervous, and how stiff does the body start to get when balance is compromised. And then some people dealing with orthoses, a lot of people with neuropathies, a lot of people with weakness, some people have orthotics in their shoes. All those things can destabilize or change balance. Reacting to feedback, what happens if you trod on something that was a bit insecure, or a soft bit of grass, or a plush bit of carpet, and how quickly do you react to that? If you walk onto some soft carpet and it affects your balance, does it take you a minute to adapt to that carpet or that grass, or does it just take you 10 seconds? And speed of adaptation and reaction to those things can be trained. So although it can be challenging to adapt, we want to improve the speed of adaptation. And the early pre-planning stuff, this is some of the more cognitive things that we add in is recognizing obstacles, being able to change speed to walk around things, changing directions, turning, all those sorts of things become an important part of gait. So from a research laboratory perspective, we really have struggled because so much of it's straight line, and so much looking at walking patterns like step length, stride length, step width, gait speed, where so much of the mobility that we're retraining is not that. There's so much more to it. So we're training a lot of new skills, and there's lots of different types of learning. And we don't choose one, we often choose multiple. We might be trying to modify the strategies that we got. We might be reinforcing strategies, and reinforcement skills is when we do things at quite high repetitions so that it becomes more neuroplastic, and then those learning takes place over the long term. The decision to learn new strategies is an important one. So if I'm a physio thinking, I think I could teach you some different ways of walking down the stairs or different ways of turning. But then what we've got to consider is, how long might that take? Can we do it safely? Do you get the opportunity to practice that safely? Or am I setting you up for something that could be quite difficult, might lead to a lot of anxiety, and might lead to you falling over? So there's a lot of things we've got to consider. We've also got to consider what you want to do. Some people really want to try something new. They're excited by that. And of course, most of the time, the customer is always correct. You've got to do what people want to do, as long as we can explain what we think is safe and unsafe and get the supports that they need. We've also got to consider what's called attractor states or movement habits. We've all got a bit of a signature walk sometimes, and we've learnt that for reasons that usually means it happen because of a reward. So that means you've developed the habit because it works. If a physiotherapist comes along and says, I want to change something, then that's not really going to change your walking unless it leads to something better. It leads to some kind of improvement. So when we talk with physios and we teach them this stuff, we can get people stronger, balancing better, stepping faster, a lovely new smooth walk where you're pushing off and you've got better knee control, and it's all wonderful in the physio gym. And then if we spy and we watch you walk back out to the car in the car park, walking's gone back to the usual walk again. And we're thinking, what the hell is going on? Why can't we get a better carryover effect? And you're not going to get a carryover effect until that new walking is actually giving you something useful. It's giving you something new. And it's also being able to be used in different situations. That's where we may have to use our other colleagues and other health professionals, so family members, occupational therapists, nursing staff, these kind of things where they can help to encourage you to implement what you've learnt new in new situations, so that's more likely to carry over into the real world. The other tricky thing is we've got to think about, if we give someone an exercise to improve their walking, at what level of difficulty do we want to make it? Now, for a novice learning, when you're learning something new, often we want to actually make the task difficulty not too difficult and give you lots of opportunity to practice, because that's the optimal level to learn. We need it to be challenging, but not too difficult. If it's too difficult, you won't get a very high dose, you won't feel very confident, and also you won't feel like you're getting anywhere fast. And often when we see balance and walking protocols, particularly in elderly care, you may see some of the things that people are doing are quite hard to do. Like you got people standing on blue bits of foam and closing their eyes and feeling quite insecure and standing in parallel bars and holding on for dear life. And so they're very challenged. And that's what a lot of therapists are taught to do, but it may be too challenging, and it's not leading to any meaningful change in any hurry. But if you are a bit more of a what we call expert learner, then the challenge point we can start to push a bit further. And that's where some people are doing things that are just too easy. They're stuck on the same sets and repetitions. The level of the task difficulty hasn't been modified. So don't expect too much progress. You'll probably start to plateau if we're not pushing that difficulty a little bit harder. So it really is trying to talk to therapists and talk to people as to how hard do they feel the task is. What I do as a physio is give people exercises to do. Let's say I give them 3 exercises. One of them is really easy. The other one's a little bit more challenging, and the other one's quite challenging. But I make sure all 3 of them are safe. But you've then got a choice when you do your exercise whether you're going to do the easy one, the middle one, and the hard one. Are you going to do all 3? Or you're having a bad day and you just want to do the easy one and do lots of the easy one? That gives you choice. And it means that you'll manage, there's flexibility there, so you manage to keep practicing. And when you're feeling good, you might do the difficult one. And actually, if you just map that over time, just jot down when you did your exercises which of the 3 you did, you may see this confidence picture emerge that, you know, after the 2nd or 3rd week, they really stay consistent with the more difficult exercise. So you can see that there's a process of choice, and there's some flexibility in what people are doing, and understanding that all 3 exercises have their benefits. So that's something that we use a bit at the moment with home exercises. Parkinson's disease is also a big challenge, and it's taught us that, and it's not just relevant for Parkinson's, it's relevant to many kinds of dementias as well, is some of the strategies we use early on in disease might be beneficial for things like falls risk, to reduce falls risk. But if we do those same interventions later in the disease, it's actually increasing falls risk. And that's not a good thing. So what we're trying to figure out is how can we intervene as people's mobility is declining more, and come up with some strategies that need to change to reduce people's risk of falls, because the strategies you did 5 or 6 years ago may not be relevant now. And that's basically advocating for updating programs and modifying programs as you go. So the time in between seeking out someone with experience in these areas, who's your supervisor or coach, if you like, you don't want to go too long. And then hopefully I've convinced you by this stage that Gait is a cognitive task. I put this on in particular because walking does involve thinking, whether it's conscious or unconscious, it involves thinking. It is a cognitive task. And what's changed over the last even 4 or 5 years is our realization that when we do gait retraining, we have to make it actually more cognitive. And there's a little bit of work, particularly in the area of Parkinson's disease, where we actually, some forms of cognitive training help with walking, even though you're not practicing walking, which is pretty amazing. And that's going to be tasks like set shifting, spatial memory, sequencing of tasks, and that may help with things like freezing of gait with gait ignition. Here's my comedy slide, which is talking about how much do you need to do of each exercise. So in terms of, some people have an exercise, they may do too much of it. So sometimes you might skip leg day with the strengthening because that's going absolutely fine. And working on what needs practice to help you improve your walking best of all. We also know the barriers. I probably don't have to tell you guys this, but obviously anything to do with exercise and lifestyle change, you don't always get people lining up for. A good example is when we've talked about, I work a lot with people with multiple sclerosis, for example, and as soon as there was a medication that came out that proclaimed to improve walking because it improved nerve conduction, we had all the neurologists talking about walking for the first time. It was quite amazing. Meanwhile, as a physio, we've been talking about it for ages and come out with interventions and research. So look, one of the biggest barriers is the fact that are people ready for, are we supporting people to engage in exercises? And then that will be important. And also, what do people believe in? So here's a bit of research, just show you the lower part, table 3 slide here, is that the biggest barrier for, say, people with Parkinson's disease to exercise was low outcome expectations. So they didn't think it was going to do much, and lack of time. So if people don't believe that it's going to work, it's not going to work, and they're not going to do it. So one of the things we're trying to do, and it's the same here with pain management in the musculoskeletal world, is we have to have a conversation with people about, well, we're going to do some work with your walking, but here's a program, and get the idea, what do they believe in? Do they think it would be of benefit? And if they don't think it's of benefit, what kind of things were they hoping, or what kind of things were they expecting? Because otherwise, it's like going into a signing a contract with someone. You want to have some kind of idea that, I'm giving you my advice, but also, do you believe it will work? And then I'm starting to think, as a physio, can I give you a couple of exercises to prove to you that it's going to work? So when you come back to me in 3 or 4 weeks, you can show me how you've improved at these aspects. And then we can actually measure that it's actually making a difference. So it does mean setting the exercise at the right level, and it does mean talking about people's expectations before we start. I've talked about load management, and that becomes really important as well. And I've also talked about the various things that we assess when we're talking about walking. So we do a lot of assessment of vestibular system. We do some, as physios, we don't assess vision in a huge amount of detail, but we do look at gaze stability. We look at saccadic eye movements. We look at smooth pursuit eye movements. We look at visual scanning strategies. We assess sensation. We look at coordination and planning. We're considering people's medical history, their level of fitness, their heart and lung function. And then we're looking at what is people's peripheral like in terms of muscle, nerve function. All these things become important. Inevitably, when you're dealing with someone, we're not just dealing with dementia, we're dealing with things like neuropathies, osteoarthritic knees. We're also dealing with a history of dizziness, which may be from a vestibular event earlier. There's many, many things. The challenge that we've got, if we're working with this slide, I don't know whether it makes any sense to you, but what we're trying to do is train different kinds of walking. Just to explain that fast walking and slow walking are both walking, but they're actually not related in the brain. They're completely different tasks. Just like running and jogging is not the same as walking. So if you want to train a slow walk, which you might need for walking, say, negotiating, walking through between tables and chairs in a restaurant or through a dining area, or faster walking when you want to head off down the street along a pathway, or steps and turning. They're all different things, and they all need different training. If we're trying to speed people up, we need to practice fast walking, but don't expect the fast walking to carry over into other forms of walking. So training specificity really keeps us quite hamstrung in the fact that we can't just do one thing and expect a change. And also, if we're going to work on walking, we have to do quite a lot of walking. It sounds obvious, but what happens is you'll go to a physio or exercise trainer or something, and they'll give you other exercise around strength and stability, balance work, some fitness work where, you know, you might be on an elliptical trainer or on a treadmill, or dart steps and stepping practice. All these things are adjuncts. They might be important, but how much time do you spend doing those things as to how much time do we spend doing the actual walking? And here's the slide that explains it a little bit further. If you're doing walking practice and you have these adjunct exercises, our challenge in physio is to try and how closely can we get the exercises related to walking. So if you're getting stronger in your calf muscles or your hip muscles, you're getting better with balance on one leg, how do we then apply that into the situation where you have to walk up the 2 steps in your home? How do we get that better when you have to do a quick side step or a pivot and a turn in relation to the real task? So we try and keep our exercise very closely related when we can to actual walking, so that it's more likely to carry over specifically into that task. Because sometimes you'll get people telling you, "I'll do your core stability exercises here, and I want you to strengthen these muscles here." And they might be important for your capacity, but how much time are you devoting to those? And is your Olympic event still walking? And if that's the case, we can say there's nothing wrong with those exercises, but let's just revisit how much time you commit to those versus these other exercises, which may be more important. So that's something definitely to consider. And we spend a lot of time teaching physios, even at postgraduate level, about how to keep our exercises we give people close as possible to the real thing. So I'll just run through now some issues that we see, and then as a physio, what we might consider with our treatment. Slowing down is a big issue. It's a sign of universal poor health. We know that. There's multifactorial reasons why people slow down: physical, cognitive issues, psychological issues. A lot of people have the just-in-case strategy, which means there's a cautious there. People have learned that it works to slow down because of, you know, cognitive reaction, processing speed issues, confidence levels. Many people who are overly cautious, we've got to try and determine whether is that something we can change, or is that quite a sensible adaptation? And then how much are people deconditioning because of slowing down? If you walk slowly, some muscle groups become involved, some elements of balance become involved, but then you're losing the strategies for the fast stuff, or the quick turns, or the quick steps that you might need to save yourself. So what we might need to do is a detailed assessment of strength and balance. We look at vestibular a lot because we're looking at balance. A lot of people, we know that in the elderly, at least 30% of people have dizziness, and dizziness really impacts on balance. We look at coordination, processing speed. We've got simple measures of cognition, particularly in a functional capacity and physical capacity stuff where we're thinking about fitness and strength. We might do specific speed-based training if that's what we're trying to do. One of the ways I tend to do that is look at people's comfortable walking speed in a certain environment and time how long it takes. And then let's say someone walks from one end of the room to the other, and let's say it takes them 8 seconds. And then what we do is they start walking from one end to the other, and I start counting down from 7 seconds to 0. And they know they've got to get to the end of the room by the time you get to 0. So what I'm doing is improving your speed by 1 second by counting you down to improve your speed and give you a bit more of an external focus, but without rushing you and without making it too different that you feel really quite insecure or feel like you're going to lose your balance. So there's these subtle changes we do to make people faster if being faster is our goal. And those make the process gradual so that the body and the brain and your confidence levels have time to progress and adapt. Dual tasking, that's slowing down or stopping when patients faced with an extra task. here's a picture of people walking in their lanes where they've got their mobile phones. Obviously, young people have this ability to walk and text at the same time. I've certainly lost that ability, or I'm particularly, I'm not very good at it. I don't know whether I was ever good at it, but that becomes an issue. So you might see people who walk, but then whenever they have a conversation with you, they stop. And that's a sign that it's becoming difficult, and they've got a strategy now not to do dual tasking. The question as a physio is, do we want to, we will definitely test dual tasking. We're always interested in how does walking performance change and how much does it change when we add in a dual task, whether it's a motor task or a cognitive task or a speaking task. But also we've got to then choose, do we want to avoid dual tasking or do we want to train dual tasking? But here's the thing, avoiding dual tasking also requires training. So the number of people we're dealing with who do some things and they automatically might grab something or look somewhere or start talking, or they have their attention is focused elsewhere. But to train yourself to think differently in certain situations takes practice and training to not do that, because you know it's safer. So that to reduce your impulsivity sometimes requires a bit of training and practice. And also we may want to add in dual tasking, especially when we want to make the skills more automatic and we want to consolidate skills. So if you're getting better at twisting and turning and dancing and stepping and walking upstairs, well, the physio may well want to then say, I want you to do that now and carry this cup of coffee, which is half full. Or I want you to do that and I want you to count down the months of the year backwards and start to do a cognitive task at the same time and just practice being able to do two things at once. So yeah. Reduced balance, well, standing balance, standing tandem or semi-tandem, standing on one leg, a bit like when you're trying to get your trousers on, get dressed, the ability to turn, the ability to reach out of your base of support, all these things impact on balance. We're very good at training balance. So we do a comprehensive assessment. We look at your strength and how stable you are. Sensation affects balance. Vestibular function will affect balance. As a neurophysio, we spend a lot of time in the vestibular rehab world. Vision will affect balance. So we might look at balance with your eyes open, your eyes closed. We also might look at balance with your vision in different situations where you're looking somewhere else, or the light's been dimmed, or you're in a larger spatial environment. We train standing balance. We train stepping strategies. And there's a lot of gamification now out there. There's a lot of mobile phone and iPad apps. There are some other bits of technology to help to randomize things. And that's, you know, when you're leaning forward and you've gone so far forward, but you need to take a step, or you lean so far forward, but you think, no, I can retrieve my balance and not take a step. And then there's this gray area in between where your brain's got to figure out, do I need to take a step? And if I do, if your brain does decide to take a step, is it a good step? Is it big enough to save your balance? Is it fast enough? And is your leg strong enough to hold your balance? Or if you're losing your balance backwards, do you take lots of little steps until you bang into something and you stumble? So we've got to train your stepping strategies, and we've got to train them in different contexts. And we've also got to train when you don't use a stepping strategy, when you need to reach over something, you don't have that capacity to step. And all those grey areas in between need a bit of training. Sometimes we use things, and I use this a lot in my practice, is to find something that's familiar, that's in your brain from your past. So if someone played a lot of soccer, I will show them some moves they do when they stop and turn and pivot, or pass on the outside of their foot. And all these lovely movements come out because they've got these memories and they've got these skills there. Or if they were very good dancers, or even if they weren't very good dancers, but they did a lot of dancing, they have these steps that come out that are more automatic. Can we tap into skills that are there and then just modify them and tweak them a little bit? Because that enables people to move. Walking, it's a bit like Monty Python, those who know about the ministry of silly walks, but we do this a lot where we get people to walk in different ways. Walk with big steps, walk with wide steps, walk with little quick steps, walk in between narrow items, walk with slightly bent knees as if you're ducking under something. So we practice walking where they're not the same, and also transitioning between those type of walking. And then how does the brain choose one walk over another? And that becomes a bit of a cognitive choice. And that's where transitions become important. And the one that's really hard with balance at the moment, but we know is probably very effective, is perturbation training. Perturbations, when we refer to unexpected knocks, like something comes along and sort of tips you over, or there's a strong gust of wind, or you suddenly slip on a slippery surface, and then how quickly do you react to that? Now, unexpected perturbations is a powerful way of training balance, but obviously is it safe? In the research lab, they do this because they have people in a harness, and then they can walk along and suddenly trip on something and then train them to react faster. And they tend to have a pretty good carryover into some elements of their balance. But you can't necessarily do that at home. And I can't necessarily do that in my physio practice because it's not a safe enough environment to do it. However, we can get a little bit creative by making our movements a bit more random. We sometimes throw in a bit of some elements of instability to make those balance reactions a lot faster. But that's certainly a work in progress as we're learning what is safe and what's not. What about small steps and shuffling? That's a big issue. So small steps, cautious steps. There's hesitation, which we call gait dyspraxia. There's freezing of gait, strongly associated with Parkinson's, but we see it in lots of other forms. We see it a lot in dementia as well. And then festination, where you've got little steps, but there's a lot of sort of momentum forward. So it's almost like you're using forward stepping strategies to walk, balance strategies. They're all trained in slightly different ways. So with we've got to assess it in the context. So some people are saying I'm having trouble with initiating my walking, but they're in the physio consulting room with me and it looks absolutely fine. Often people are at their best when they're with their physio, which makes it challenging. So we've got to try and induce the problem and see it in the real context. Dyspraxia is a movement planning disorder, and often we think that a lot of errorless learning strategies work with that to practice in the context of things. Freezing of gait, there's not one form of freezing of gait, there's many subtypes, and often they respond well to things like cueing, and if visual cues or auditory cues, different sort of cognitive thinking about thinking to sort of improve the way you take that first step to get going. But then we might want to train people where cueing has worked and make it a little bit more cognitive, where they don't have external cues, but they now have to think of it on their own. So that sometimes we use what's called internal voice. So some people say, step with your right leg, and the physio's been saying it, step with your right leg, and your husband or wife's been coaching you with it. Now you've got to say, step with your right leg out loud yourself. And then you start saying, step with your right leg, but you're saying it inside your own head, no one can hear you, but you're thinking it. And then the other thing is, will you think of that strategy when you're anxious? Or will you think of that when you're in a rush to go to the toilet? Will that strategy come and be there when you need it? And can you train it that well that it'll actually happen in those situations? So the cognitive aspect is becoming probably the next frontier, if you like, with our research and our practice in neurological physio. The ability to stop is important. And I put there at the end there, we do need to practice a lot the elements that you're struggling with. Gait ignition, here we go, hesitation, freezing, ataxia. So some people's feet stick to the ground. So even though they want to go, the feet saying no, that's because maybe balance is compromised. Anxiety is often linked with this. Now, some people may see a medical practitioner or a health professional and they say that it's the anxiety causing it. It's the anxiety is why you're struggling with this aspect of your walking. And what we find is, particularly in the area of vestibular rehab, is a lot of people walking in an open environment or walking across a field of grass or walking across a tennis court or crossing the road is a completely different visuospatial environment and requires completely different balance strategies than just walking across the bedroom. And so we need to train them in context. And it may make you anxious, but often it's not anxiety that's causing it. Anxiety may be making it worse, but anxiety is caused because the situation is quite difficult. And as a coach, I'm telling people that those situations, you're anxious because your balance is really challenged at that point. And that you've got to acknowledge that there are some situations that are far more difficult in balance than other situations. So you can see why education becomes important with that. With some issues, like with Parkinson's disease, medication review becomes really important because medications can dictate, medication can improve freezing of gait, but sometimes medications make freezing of gait worse. So there are different forms that we have to consider, and we will talk to the neurologist about that. And then building up confidence is an important part of our treatment. And usually when I'm teaching this to physios, we're making exercises easier, but more intensive so that we get the practice in. Sometimes we've got lovely exercises, but we don't do anywhere near enough to make a difference. I'll whiz through some of these. So leaning posture, stooped or flex posture, lateral leans, what's called Pisa syndrome, leaning backwards. We see dystonia as a movement disorder with some people, and also adapting to pain. So if you've got a history of low back pain, you may have been changing your posture over time to avoid pain, or your motor control has changed. We've basically got to assess people to determine how much is a structural problem, how much is a stiffening strategy because of the way their postural control is adapting. We want to do balance tests. We want to understand people's perception. Some people lean backwards because they feel like they're falling forwards, and we need to understand what their perception of verticality is like to understand that if we're going to improve their leaning forward, we have to probably recalibrate their sense of space and where they are. So our treatments maybe become far more perceptual than they are actually a motor strength task, if you like. So we combine perceptual training and motor training together to different ratios with some people. And if pain is an issue, we've just got to basically manage the pain the best we can and work with it and try and figure out how that's influencing people's posture. When you think about walking, you don't always think about the trunk, or you don't think about the arm. But if you watch people, they may be quite rigid in their arms. They may not be swinging their arms. We know this is common in Parkinson's disease, but it's common in a lot of degenerative neurological situations. And it's a reflection of rigidity. It's also a stiffening strategy, which means people are finding balance difficult. They're getting a lot of co-contraction. We know co-contraction occurs when people are under postural threat. So you can get a young person and give them postural threat and rigidity, and all you have to do is get them to stand on a platform and raise that platform up 10 meters and look at how their postural sway changes and how their muscles co-contract, because there's a threat of falling over. But that threat can just happen in a slightly different environment at home for some people. So it's understanding that postural threat influences the way you balance. It also may delay, if you're stiff, are you going to get that step out in time to practice? So it's stiffening strategies may be good for keeping a balance in some situations, but it may be impairing more adaptive dynamic balance situations. So we need to assess all of those. We might be practicing things. And one of the things we do is get the range of motion to start with. So get people moving and free up a little bit, and then use those movements in the context of stepping and balance. But also we might apply rules saying, I want you to walk, but I want your head to move in these positions. I want your trunk to move, to encourage these new movements and see if they can come on board with your walking. And we just want to limit the secondary stiffness. If you're rigid and you stay rigid, it doesn't take long before everything gets quite stiff. The whole rib cage, your shoulders, your neck becomes stiff, because and so that can lead to secondary issues in terms of discomfort, and you're basically limiting your movement repertoire. Coordination, we often do a lot of sensory priming. This is a picture of a weighted vest, because this is the way we often increase the sense of gravity, which makes some people feel a lot more stable. But then if you're standing up and sitting down with a weighted vest, we're increasing the load, so we're making you work harder. So it's a good strengthening strategy as you're getting stronger, but it's also a good way to make people feel nice and stable. So weighted vests and even weighted blankets sometimes are very good. They also settle people down when they're feeling like their coordination is a bit off, because it's probably giving more consistent feedback about gravity as well. Cautious gait, slow and careful steps, worse in different environments, which I've talked about. Anxiety, people often don't fall, even though they've got a really overly cautious gait. What do? Well, we don't train you to be a bit more reckless. We have a careful assessment of your balance. Vestibular conditions, dizziness, vestibular balance issues are really common. So we do a very thorough assessment of vestibular. If you've got something like positional vertigo, thankfully we can treat that relatively quickly. Visual dependence means how reliant you are on your eyes. Now, if someone's reliant on vision for their balance and we get them to close their eyes and they feel really anxious and their balance isn't very good, well, we don't want to train you with your eyes closed, but we might train you with a pair of sunglasses on, or we might get you to close one eye, or we might dim the lights and get you look in a different direction, because they're more realistic for what you might be dealing with in day to day, and that's where you may need the training. There's a lot of education about and a lot of confidence building. And again, we're talking about supports and expectations. Dizziness. I can't help myself talking about dizziness because as a vestibular practice, we see lots of people with dizziness. We see lots of people over the age of 55 with positional vertigo, with disequilibrium, with persistent dizziness issues. The good news is we've got a lot of really good treatments, and it's not one of the best managed things historically in medicine but the evidence is very clear. It's just that we haven't implemented it. Neurological physios in Australia have taken a very lead role in vestibular rehab, and I don't know what it's like in other countries, but what I'm pushing here is for more physiotherapists and more GPs to be better at assessing dizziness and to get people fast tracked, because you need a specific diagnosis, and we've got very specific treatments if you're dizzy. But also the wait and see approach is what we were taught in medicine decades ago, and it's still happening in practice now. You don't want to wait and see if you're dizzy. You want to be assessed by someone who's got experience in assessing dizziness, and you want to get onto treatments as soon as possible. Because what happens is people feel like they're getting better, or they say, well, they're not coming in to talk about the dizziness, but what happens is they're putting up with it. And they've stopped moving, and they've stopped going out, and they've stopped going to the supermarket because they feel really nervous and they feel a sense of anxiety and dizziness. And so it leads to social isolation very quickly. It leads to deconditioning very quickly. And what if some of those things were treatable, particularly early on? So that's something we really want to change quickly. And also just to realize that what vestibular has taught me as a clinician is to train the visual spatial aspects of training. That is your cognitive awareness of what's around you, what's behind you right now, and do you remember it's there? Is there a door behind you? There's a door behind me somewhere, but which direction is it? And if I'm moving towards it, have I got a good spatial cognitive awareness of landmarks and boundaries? Because that really has a big effect on the way I move and the way I balance. You can train that. We can train visuospatial memories. We can change moving to different targets. And it's not just for dizziness patients, it's for balance training. Well, with weakness, we're dealing with often people who are very weak. And so we've got to set exercises accordingly. We may need to adapt. Some people have neuropathies and peripheral changes and musculoskeletal conditions that need careful assessment. Sorry, I'm whizzing through the slides quite quickly because I'm aware of time. Strengthening, we have to consider, it's not just sets and repetitions of lifting weights or doing pulleys. It's like, how fast do we need to hold things for certain functions? Slow, controlled movements. How many do I need to do? If a physio says, I want you to do 3 sets of 10 of these exercises, well, that's fine. But what's the reason for that? And is that going to change over time? Do we want to end up doing 4 sets of 10? Or do we want to do 2 sets of 5 of really difficult, really heavy exercises? So, and how fast do I do it? So all those things take consideration. How much time? Do you need rest days in between? So there's a lot to consider with the exercise prescription. It's not rocket science, but a lot of people have generic exercise and they're left with them at a certain dose. And we can't really expect changes to things like walking unless we're actually modifying and changing things. And you also got to think about specifically what task. How strong do you need to be to get up your stairs? And how strong do you need to be able to step down the gutter? Or how strong do you need to be to sort of leap over a puddle? All those things become really important. Pain. I'll just say probably the biggest thing that's affecting the physio world at the moment is talking to people about their beliefs, and also undoing some of the damage being done by fearful language. One of my favorite acronyms is VOMIT, a victim of medical imaging technology. What that is, people coming to us as a physio say, I went to the doctor and we had an x-ray of my spine and he said, my spine is crumbling and it's degenerative. And they're using all this damaging language. And I can't do too much walking because I've got a bone spur pressing on a nerve and it's doing me all kinds of damage. The language that's used with things like spurs and, stress fractures and crumbling and degenerative is all very destructive. And look, a lot of these are a normal part of aging. And imaging, while it can be useful, can be over-interpreted, and it creates a behavioural change, particularly in relation to pain and movement. So what we do is we do a lot of unlearning of those things. I've read your scan, I've had a look at it, but there's nothing unstable or unsafe. And there is a way of doing some exercises safely. And that takes a bit of undoing for some people because they've got some other belief that there's some damage that's going to be done. And it's very rare that we're going to have someone with an unstable spine or a crumbling knee where we're going to do all kinds of damage. It's more about education, about loading and inflammation and pain, starting basically and being quite conservative, all these kinds of things, but we can get people moving better with pain. And also to realize that we assess things quite detailed in a detailed way. We can adapt our treatments. We can set goals. Are you doing walking training to improve your pain, or are you doing walking training to improve your walking? People come back and say, my pain level is just the same, hasn't changed. But what's happening is they're walking 3 times as far now before that pain actually comes on. So you're making some gains because you're able to do more now, and your pain isn't interfering quite as much. So it's been clear, looking at medications, looking at sleep, which is really important, and then teamwork. We can't manage things like chronic pain on our own. So it's really talking with doctors, it's talking with support people around you to manage pain more comprehensively, because it has a big effect on walking. And then functional gait. This is where sometimes the brain comes up with movements that's maybe of what they call not an organic cause, and you get some quite bizarre movements going on. It is really common and it affects walking a lot. This is where you might do some weird double step or some extra hitching of your body, or some overly bizarre lean of your body. It's common as an overlay with a lot of degenerative neurological conditions. It used to be called hysterical movement disorders or psychogenic movement issues, which has stigma associated with it. And it's an area of practice that really has fallen between the cracks of the neurology world and the psychiatric world. But what's happening now is the rehabilitation world is picking up because it's very, very common, and physical rehabilitation in particular works really well with these patients. And what that means is, to get a clearer diagnosis, there is a functional component to your movement problem. Education and support, consistent messages between, say, the medical specialists, your physiotherapists, your GP, so that we're all on the same page. To know that it's not a deliberate psychological action. It's not like that there's some kind of workers' compensation claim at the end of it, or you're not deliberately doing it just to be difficult, that it is an actual functional unconscious neurological condition. And for that reason, we do a lot of external focus of attention. So we're not focusing in on the body too much, because that often makes things worse. We progress things slowly. We need to differentiate what's the functional component versus other conditions. So I have people with functional gait disorders come to me, but they do have a severely painful osteoarthritic hip, and we may need to manage that hip first and foremost before we start doing our movement retraining for the functional element. So and then we have to do, usually with these patients, a bit more slow changes to give everybody and everything time to adapt, and that's by setting milestones. And last of all, walking can vary dramatically. In the morning you might be walking well, in the evening you might be walking quite slowly, you might be leaned over, your back's quite sore, or you've got more hesitation with your steps. Sometimes you're confident, sometimes you're not. We see these huge fluctuations, and often when people are getting worse over time, the fluctuations are getting bigger. The best of walking is so much different from your worst of walking. What that usually means is we have to improve your capacity so that you're a bit more consistent over time, and figure out why is it varying so much. And one of the things might be things like conditions like vestibular stuff, where you're dizzy. Migraine sufferers have huge fluctuation in sensory integration and performance. Autonomic blood pressure fluctuations. Medications. So your medications might, for things like Parkinson's disease, or for things like when you're managing your pain, when they kick in, you move better. When they start to wear off, there's quite significant changes. And then fatigue. So motor fatigue is something I've been interested in a lot. That's like the performance of your muscles might be fine, but if we keep pushing it, how quickly does a very strong muscle suddenly just decide to become very weak? And that's where some of our testing in the clinic say, oh, you're very strong in your quads, or your calves are really strong, but then your calves are really strong after you've done a 5-minute walk, and do things drop away a little bit. And there's a lot of conditions that can contribute towards that. And a lot of people do have chronic fatigue syndrome. So performance and energy levels fluctuate dramatically. So it's really trying to set the appropriate exercises. We do tend to move away from generic programs. There's nothing wrong with generic programs, but as long as we can introduce them at the right time, and set some expectations around that, and also how to, a lot of people go to say Strength for Life classes or balance classes of my patients, but they've got one or two of their own exercises that might do as a warm-up. So they still get their own little slant to it, but they're still doing more generic programs as well. Oh, there's my last slide. I don't expect you to read that, but that is references that I use for this talk, so that you feel like I haven't just made it all up.